it is probably time for us to get started. So I am Elizabeth Schwartz, Elizabeth S., who is referenced here. I'm the president of CPHA. And on behalf of the entire board, I want to thank you guys for helping us celebrate National Public Health Week. This is our big event for the week. CPHA has been around since 1916, if you can imagine that, and we couldn't continue to serve the public health community without your participation in events like this, so a big thank you. I'd also really like to thank our Health Education Committee, and in particular, Jamie Lockhart, the committee's co-chair for organizing this event. As an educator myself, I know that health education and the growth mindset that really underpins it is fundamental to what we do as public health practitioners. So I am super glad that you guys are all here to keep on learning. Before I forget to mention it, this webinar is being recorded, just throwing that out there. In that vein of education, for those who qualify, this webinar can be used for one CHES or MCHES continuing education credit. I know somewhere on our website we said it was fewer, but it's one credit. If you do want CHES or MCHES credit, you have to complete the evaluation that I'm going to share with you guys in just a moment. For those who are not looking for CHES credit, you are still absolutely welcome and invited to do that evaluation just to give us a little bit of feedback about today's event. But let's see, to admit more people here. So with that, I would really like to introduce to you guys our guest speaker today, Dr. Kim Doughty. Dr. Doughty is an assistant professor and director of the undergraduate public health program at Fairfield University. She received a BS in Nutrition and Dietetics from the University of New Haven, a master's degree in public health from Southern Connecticut State University, and a Ph.D. in public health nutrition from UMass Amherst. Prior to joining Fairfield University, she was a researcher and co-authored peer-reviewed articles on topics including effectiveness of school-based obesity prevention initiatives and the impact of dietary interventions on cardiometabolic risk factors. Her strongest interests are in maternal and infant health and breastfeeding promotion, and her recent work has explored the differences in breastfeeding by maternal diabetes status. Also, as it happens, Kim was one of my instructors when I was in grad school and was a mentor to me as I transitioned into teaching. So I know that we're in for a real treat today. After her presentation, we're going to try to have a little bit of Q&A, but please feel free to put your questions in the chat box. With that, turning it over to you, Kim.
All right, thanks, Elizabeth. Thank you so much for that wonderful introduction. So good afternoon, everyone. I'm really excited to have the opportunity to speak with you all today about issues in early childhood nutrition. I love talking about this topic because I think it's so important. If we want to improve public health and especially prevent chronic disease, I think we need to start young. That's when we're going to have the most impact. This topic is also directly related to some of my current research interests, which are understanding the barriers and facilitators of breastfeeding among women who had gestational diabetes during pregnancy. And on that note, I hope this is allowed, but I'm currently recruiting for a qualitative study on this topic. So I'm looking for women who had gestational diabetes who are within about a year and a half postpartum. And I'm having trouble reaching this population. So I'm going to just drop the flyer, the study flyer in the chat. And if any of you work with this population, or if you know anyone who might be eligible, please feel free to share that. So I did just put that in the chat. Okay. So the objectives for today, I'm expecting that by the end of this hour, you'll be able to identify some key nutrition-related recommendations for early childhood, which I'm defining as birth to 5 years, and describe how well the US population meets them. You should also be able to identify the most salient nutrition-related public health problems for young children in the United States. And finally, to describe some evidence-based solutions that exist for these problems. But before I jump into all of this, I want to know a little bit about who I'm talking to. So if you could take a moment to write in the chat your organization and or your role. I think that would be really interesting for me to see, what kinds of public health professionals are represented here today. Oh, I see. Some of you have already done that as you're renaming yourself, so that's helpful. So we have some local health, healthcare. Great. Wonderful. Oh, East Shore, that's my health district. I live in North Branford. Great. Oh, WIC. I'm going to mention WIC a couple times in this presentation. Great to see someone from that program represented. Great. All right, thank you so much. And next, write in the chat a rating of your own level of knowledge about early childhood nutrition, ranging from 1 to 5, where 1 would be very little knowledge and 5 would be extensive knowledge. Again, helps me to know kind of where people are starting out. Okay, a lot of people kind of in the middle or a little below maybe the middle. Right. Great. Well, regardless of where you're starting, I hope that we'll be able to bump you up a little bit on that rating today. So the first thing I'm going to talk about is the current recommendations for early childhood nutrition. And many of you may know that the most recent iteration of the Dietary Guidelines for Americans, which came out in 2020, was the first to include specific guidelines for infants and toddlers. So for a very long time, the DGAs did not even address the population under age 2. And finally, it does. And so I'm going to use this as a framework for this discussion. So I'm just going to go through the key dietary recommendations for infants and toddlers first. The recommendations for older children or 2 to 5 is really pretty similar to the recommendations for all adults, which is to eat a healthy dietary pattern. But I want to focus on these first because they're new and they're specific to this infant and toddler population. So the first 3 recommendations all relate to infant milk feeding. So it's exclusively feed human milk for about the first 6 months of life and continue feeding human milk through at least the first year and longer if desired. I have an asterisk there that I'm going to explain in a moment. And feed iron fortified formula when human milk is not available. So the asterisk was to indicate that after these DGAs were released, so it was in June 2022, the American Academy of Pediatrics updated its recommendations for infant feeding to include continued breastfeeding for 2 years. So instead of 1 year, now it's 2. And I'm sure many of you understand why breastfeeding is recommended for as long as it is and why exclusive breastfeeding is recommended for 6 months, but it's easy to lose track of what benefits are actually evidence-based, what do we have a lot of research to demonstrate, and what are we less clear on. So for infants, there's really consistent evidence that breastfeeding is associated with reduced risks of infant mortality, SIDS, and all of the conditions that are listed here. And also for lactating people, there are consistent benefits of breastfeeding for reducing risk of type 2 diabetes, which is part of the reason why I'm so interested in breastfeeding in women with gestational diabetes, because they have an increased risk of type 2 diabetes, also hypertension and breast and ovarian cancer. And some recent research showed that there is continued risk reduction beyond 1 year of breastfeeding, which is what prompted the AAP to update that recommendation from 1 year to 2. So I'm going to do a little poll. I'm curious how you all think we're doing in meeting these recommendations. So again, if you could just put in the chat, think about what % of US infants do you think are exclusively breastfed for 6 months? So that's the current recommendation. What % of infants do you think are likely reaching that? Okay, pretty good guesses. Yeah, a lot of you are pretty spot on, actually, very close. um, before I give you the answer, I'm also going to ask, what percent of US infants do you think are breastfed for 12 months? So not necessarily exclusively, but just continued breastfeeding for 12 months. Okay. All right, so most people are guessing somewhere around 10 to 25, maybe more percent. Okay. So I think some of you might be pleasantly surprised then by these statistics, at least for continued breastfeeding. So for exclusive breastfeeding, it's just about a quarter of infants in the US are exclusively breastfed for 6 months. So those of you who said 30, you were really close. And for those who are breastfed through 12 months, it's about 36%. So more than what some of you said. But it's still a minority, right? Certainly, most infants are not reaching these milestones. And as I'm sure will come as no surprise to anyone in this Zoom room, there are disparities in breastfeeding by race and ethnicity. So in particular, non-Hispanic Black infants are much less likely to be breastfed at all. So what this is showing you is any breastfeeding by race and ethnicity. So the yellow line is non-Hispanic Black. The other racial groups are all kind of mixed in here. The dotted line represents overall. So, you know, there has been somewhat of a narrowing as breastfeeding initiation rates are increasing over time, really for all groups, but especially for non-Hispanic Black. So there's some success here, but there is still a pretty big disparity that needs to be addressed. And there are, you know, some public health implications for this disparity. Studies have estimated that among non-Hispanic Blacks, excess morbidity and mortality due to suboptimal breastfeeding is 1.7 times higher for acute otitis media or ear infections, 3.3 times higher for necrotizing enterocolitis, and 2.2 times higher for child deaths compared to a non-Hispanic white population. And any breastfeeding of non-Hispanic Black infants is associated with a 17% reduction in infant mortality. So, you know, it stands to reason if we can further increase breastfeeding rates and duration and exclusivity in the non-Hispanic Black population, we could prevent many, not only illnesses, but also deaths among these infants. So one more poll, what percent of breastfed newborns do you think receive formula in the first 2 days of life? So these are infants whose parents have said they want to breastfeed them. Okay, 20, 35, 10. Okay, all pretty good guesses. So it's nearly 1 in 5. So those of you who said 20% were pretty spot on. Nearly 1 in 5 breastfed newborns receives formula in the first 2 days of life. And this is, you know, potentially problematic for establishing and sustaining the breastfeeding relationship. I will point out that there are mixed findings on the effects of early formula supplementation, so it's not entirely clear. I will say prospective studies tend to consistently show that early formula supplementation is associated with less favorable breastfeeding outcomes, including higher risk of not fully breastfeeding or not exclusively breastfeeding by 1 to 2 months, and higher risk of stopping breastfeeding by 2 months. Studies have also shown that even short-term formula supplementation is associated with changes in the infant microbiome. However, there have also been some randomized controlled trials looking at the effects of early formula supplementation, and they don't tend to find significantly reduced rates of breastfeeding. However, right, so this one in particular, 2018 study, found no significant effect on breastfeeding rates at 1 month, 6 months, or 1 year of age. However, if you look at the actual percentages of infants who were breastfeeding at 6 months and 1 year, they are higher in the control group that did not receive the early limited formula supplementation. This just wasn't statistically significant. Now, there were about 80 infants in each group in this study, so that's pretty robust for this kind of intervention, but it's not a huge sample size. So this is just my own speculation. In a larger sample, I think maybe this difference would have been statistically significant. But just pointing out, this isn't something that's very clear. So we do need more research to understand what the impact of early formula supplementation is on long-term breastfeeding outcomes. So the next key dietary recommendation for infants and toddlers is to provide infants with supplemental vitamin D beginning soon after birth. The American Academy of Pediatrics recommends 400 IUs per day, but only 27% of infants met intake recommendations for vitamin D between 2009 and 2016. So we have a lot of work to do there. It's even lower, the percent who meet the recommendations for breastfeeding infants, so it's 20.5%. And it's lowest for breastfed infants in households with a high school diploma or less. In that group, under 10% of infants met the recommended intakes for vitamin D. Okay, I've included two recommendations because they're related. At about 6 months, introduce infants to nutrient-dense complementary foods and introduce potentially allergenic foods along with other complementary foods. So it used to be believed that waiting to introduce potentially allergenic foods like peanuts, for example, would reduce the risk of allergy. And research has shown that it's actually the opposite. And so it's better to introduce those allergenic foods at the same time as other complementary foods. So the rationale for the recommendation to introduce complementary foods at 6 months is based on evidence that there's no nutritional benefit to initiating complementary foods sooner than that. And instead, there's a possible increased risk of overweight or obesity associated with earlier introduction of complementary foods. National surveys estimate that a pretty large percentage of infants receive complementary foods at a very young age, before 4 months even. Depending on the study you look at, that estimate is anywhere from 16% to about 32% of infants. And this does vary by region. So what this is showing you is the percent of children introduced to complementary foods before 4 months of age across states. So in Connecticut, it's 30 to 35%, but in some states, it's as high as 40% or more. And as we're introducing complementary foods, and as toddlers begin consuming more solid foods, we should be encouraging them to consume a variety of foods from all food groups, including foods rich in iron and zinc, particularly for infants fed human milk, because human milk is low in iron. And iron deficiency affects 13.5% of children between the ages of 1 and 2 years. So it's not uncommon by any means. And adequate intakes of iron are not guaranteed, especially for those who are not consuming another source of iron, like a fortified cereal. So this study that created this graph looked at the percent of infants who were below the estimated average requirement. So that's not, you might be familiar with the RDA for different nutrients, which would be the amount that we set as the target. It's what 95% to 99% of the population would need that level or less. The estimated average requirement is just what it sounds like. It's the average requirement for everybody. So if an infant's below that level, they're likely to be inadequate in that nutrient. So for infants who do not consume infant cereals, which are fortified with iron, 95% of them are consuming below the estimated average requirement for iron, and 60% are consuming below the average requirement for zinc. And that's compared to those who are consuming infant cereals, 20%, which is still not a small number. 20% are below the recommendations for iron and below for zinc. Continuing along the theme of promoting a healthy diet in growing children, limit foods and beverages with added sugars, and limit foods and beverages higher in sodium. And finally, as infants wean from human milk or infant formula, transition to a healthy dietary pattern. So these last three recommendations really are about just promoting intake of foods that we know are health promoting and limiting intake of foods that we know are potentially harmful to health. So now I'll share a little about what we know about how infants and toddlers are doing on these recommendations. So this is selected data from the Feeding Infants and Toddlers study. It's a large randomly selected sample of the US population and looking at intake in a previous 24-hour period for infants and children between the ages of 0 and 24 months. So for these first two columns, we'd really like these to be 0, because infants under age 6 months should not be having, if they're meeting the recommendations, any complementary foods at this point. So these numbers are higher than they should be. And then for these two categories, consumption of vegetables and fruits for 6 months to 24 months, we'd like these to be as close to 100 as possible. Ideally, all infants and toddlers should be eating vegetables and fruits every day, right? So potentially a quarter to even 30% potentially of children in this age group are not eating a vegetable or not eating a fruit on any given day. And then these two categories, infant cereal and any meats, are important because they contain iron and zinc, which are nutrients that infants and toddlers have a hard time getting enough of. So these we'd like to be as close to 100 as possible, or at least the combination of them. So not every infant needs to be eating infant cereal every day and meats every day, but at least one of them in order to be getting enough iron and zinc. So these are also much lower than we'd like to see. And finally, the last three categories are foods that we'd like to see as close to 0 as possible. So for this age group especially, the recommendation is to limit sodium or avoid sodium, foods high in sodium, I should say, and avoid added sugars. And we see that by age 18 to 24 months, 80% of children are having some kind of sweet food, which includes sugar sweetened beverages on any given day. And 31% of them are having sugar sweetened beverages on a given day. And even as young as 6 to 12 months, these are also pretty high. Just an FYI, the savory snacks included things like chips and popcorn and things of that nature. There are also several differences in food group consumption by race and ethnicity. I didn't want to outline them all, but I will point out that more non-Hispanic Black children consume sugar-sweetened beverages, actually 45% of them, as compared to non-Hispanic White or Hispanic children at 25%. So some important disparities here as well. And then looking forward a little more, so for ages 12 to 23 months, the consumption of added sugars was about 104 calories per day. Again, the recommendation is to avoid them altogether. Average sodium intake was 1,586. The limit is 1,200. So we're not doing so great here. And we see the same pattern for children ages 2 to 4 years. So this is showing you the percent of children in this age group who are not meeting the recommendations. So for added sugars, a little more than half of children are exceeding the limit for added sugars. But for saturated fat and sodium, practically all children are exceeding the limits, or the vast majority. Again, this is age 2 to 4. And the reason that this is so important is because we tend to start at this age 2 to 4 is about as good as our diets are going to be for a while. So research has shown that adherence to the dietary guidelines, which has been measured by the Healthy Eating Index, which ranges from 0 to 100, 100 being like perfect adherence to the dietary guidelines. This adherence declines with time until finally kind of going back up as we get older and into middle age. So children at ages 2 to 4 have the best adherence that they're going to have until they're 60 for the most part. So we want to start these kids as close as we can to reaching all of the dietary guidelines. Okay, so now that I've laid out the key recommendations and kind of where we stand, a little bit about their rationale, I want to highlight 4 problems that I see, in my judgment, as public health problems related to early childhood nutrition. So the first one is suboptimal rates of exclusive breastfeeding to 6 months and continued breastfeeding for 1 to 2 years, and the racial disparities in breastfeeding. There are a few effective solutions. The first is the 10 steps to successful breastfeeding. So these are 10 steps for supporting and promoting breastfeeding. It is encouraged that all hospitals and facilities that serve women and newborn infants comply with these 10 steps. The first one has 3 parts, but the first 2 relate to management procedures. So things like having a written infant policy that's infant feeding policy that's routinely communicated to staff and parents, having ongoing monitoring and data management systems to track infant feeding progress, ensuring that staff are adequately trained to support breastfeeding. And then the final 7 steps are clinical practices. And they include things like discussing the importance of breastfeeding with pregnant women. So starting that education before the infant is born, facilitating early and uninterrupted skin-to-skin contact, support mothers to initiate breastfeeding as soon as possible after birth, continue to provide support to initiate and maintain breastfeeding and to manage common difficulties, not providing breastfed newborns any food or fluids other than breast milk unless medically indicated. And that unless medically indicated part is a little bit fuzzy, and I could write a whole dissertation just on that. Enable mothers and infants to remain together and practice rooming in 24 hours a day. Support mothers to recognize and respond to their infants' cues for feeding. Counsel mothers on the use and risks of feeding bottles, using artificial nipples and pacifiers, and coordinate discharge so parents and their infants have timely access to ongoing support and care. So reviews have generally supported the effectiveness of the Baby-Friendly Hospital Initiative, which promotes adherence to these 10 steps or promotes the implementation of the 10 steps. And in fact, one intervention that was designed to increase compliance with the 10 steps across many hospitals in the South was associated with a 9.6 reduction in the disparity in breastfeeding initiation between Black and white infants. So there's good reason to believe that this approach, this intervention is effective and would help to reduce disparities. However, I will point out that some steps have more evidence for effectiveness than others, and there was a recent critical review of the Breastfeeding Friendly Hospital Initiative that identified some potential weaknesses and lack of evidence, but prenatal and postnatal education and skin-to-skin care came up to the forefront as the aspects of the 10 steps that had kind of the most consistent evidence for effectiveness. So continuing with this same problem, suboptimal rates of breastfeeding, another type of intervention or solution that's been found to be effective is WIC peer support interventions. These are widely considered to improve breastfeeding outcomes. Also, breastfeeding education and support programs outside of WIC that are led by either health professionals or non-professionals, at least in terms of initiation, affecting initiation of breastfeeding. So these last two, these are from systematic reviews, prenatal and postnatal education. So along the same lines, when combined with interpersonal support and those that involve family members, partners, and other family members. And those have been found to improve not just initiation, but also duration and exclusivity. So we have some good evidence-based solutions to improve breastfeeding rates. Now, the second problem, I think, is high obesity rates among children of all ages, really, but it starts even in this younger group that we're talking about today. So just to show you what the current trends are, and this goes up to 2018, it's the most recent data I could find. A few years ago, we had started to see in this 2 to 5 year age group that there was a decrease in obesity, which was really encouraging, but unfortunately, it seems to have surged again. And so we're still on an increasing trend, even with this 2 to 5 year age group. And this is really important because, children who have obesity are much more likely to continue to have obesity as they get older and as adults. So we're really not going to get control of obesity among adults until we get control of it in children, and especially young children. So what are the solutions for that problem? So unfortunately, there are really limited studies on interventions in children less than 5 years of age. And I scoured the literature. I tried very hard to find some effective interventions that target this age group specifically. And I just couldn't find much of anything. What I did find is that interventions to reduce screen time are recommended by the Community Preventive Services Task Force, and that's recommended for children 13 years of age and younger, and that includes the 0 to 5 age range. So reducing screen time may help to reduce obesity rates even in this younger population. And this recommendation was based on strong evidence. So we have good reason to support those types of interventions. So although I wasn't able to find much else that was really tested and demonstrated to be effective, I think there's the possibility that promoting the development of healthy eating habits at home during infancy and early childhood may also help to prevent obesity. So this table is from a publication by Birch and Ventura. It is based on research, but it's not based on intervention studies. It's more based on what we know about how children develop their eating habits. So the things that we could be telling parents to do, first, promoting breastfeeding again, but also offering healthy foods, using repeated exposure to promote acceptance. So the more often that you offer a healthy food like fruits and vegetables to children, the more likely they are to eventually accept them. Although I will say, I have a 10-and-a-half-year-old who still has a very short list of vegetables and fruits that he eats. So I just feel like I have to disclose that when I share this, because it's what's recommended and the evidence says it works, but sometimes, it doesn't always translate to practice. Provide guidance on age-appropriate portion sizes and energy density of foods. Importantly, discourage the use of coercive or restrictive feeding practices. So things like you have to clean your plate, or you have to eat your broccoli before you can have a dessert, or you can have a cookie, but only one cookie. That kind of controlling feeding in early childhood seems to have the opposite effect of what most parents intend. They mean well, they're trying to promote healthy eating habits, but it tends to actually promote overeating and increased desire for the restricted foods. So we want to discourage those types of practices. We can encourage parents to find ways to reduce energy density of foods. So substituting whole milk for 2% milk, or using less butter or oil in cooking vegetables, things like that. Really simple changes. Also provide guidance on responsive feeding, recognizing hunger and fullness, especially in infants. You know, some parents might have a tendency to encourage their baby to finish a bottle, even when the infant's showing signs that they're full and they don't want any more. So being responsive to those cues can help encourage the development of healthier eating habits for children. Shared feeding responsibilities. So this means the parent decides what foods are offered, but the child decides how much to eat. That's typically how the responsibility should be divided to promote good habits. And of course, parents need to be positive role models and actually do the things that they want their children to do when it comes to eating a healthy diet. Okay, the third problem that I want to talk about is this generally low adherence to dietary guidelines for infants, toddlers, and young children. So the excess added sugars, excess sodium, not enough fruits and vegetables, not enough foods that are rich in iron and zinc. Solutions, so WIC is a great solution. 24-month-old children who participate in WIC for a longer period of time have been found to have better diet quality. And longer participation is also associated with better diet quality by age 5. And the food package changes that were implemented in 2009 were associated with an almost 4-point increase in healthy eating index score among children participating in WIC. So WIC's doing a really great job actually to improve adherence to dietary guidelines and overall diet quality in the children who participate in that program. However, effective interventions for the general population are really lacking in this area. A recent 2018 Cochrane review concluded that despite identifying 55 eligible trials of various interventions designed to increase fruit and vegetable consumption among children, the evidence remained sparse. So they looked at all of these studies, all of these interventions, and couldn't conclude that any particular intervention was especially effective. So that's kind of a downer. However, whoops, skipped something. Okay. Gardening interventions have some promise. I don't think we're at the point where we can say they're, an evidence-based intervention, but most studies do show small but significant increases in vegetable consumption. However, most of these studies haven't been very rigorous, so the quality of the evidence is pretty low. But there's maybe some potential here for gardening interventions to be part of the solution for low diet quality among this age group. And the last problem that I'll highlight is low intakes of iron and vitamin D. So WIC, again, stands out as an effective solution. WIC participants have higher intakes of iron between the ages of 6 and 24 months, and higher intakes of vitamin D at all ages from 0 to 4 years than eligible non-participants. But again, we're lacking interventions to increase compliance with these recommendations more broadly. So I think we know how to address iron deficiency and suboptimal intakes of vitamin D. We can recommend vitamin D supplementation, and we can recommend intake of iron fortified infant cereals and meats that are high in iron. But as far as population-based interventions that can actually get people to make those changes, those don't seem to exist as of yet. So in conclusion, I wanted to share with you some recommendations for what public health professionals can do now to improve the nutrition of infants and children under age 5. So I think you can promote breastfeeding through education, peer support programs, and advocacy. Provide education to parents about these new dietary recommendations for infants and toddlers that they might not be aware of. And we can advocate for sustaining and expanding the WIC program because we know how effective it is. And consider implementing screen time reduction and gardening interventions potentially. And what public health professionals and researchers should do for the future is develop effective interventions to improve diet quality and micronutrient consumption, especially iron and vitamin D, among infants, toddlers, and young children, because we just don't have enough of those effective interventions at this point. And these are my references. At this point, I'm happy to take your questions.
I have a few questions, Kim.
Okay.
First off, thank you so much. That was very interesting. And yeah, you did really great there. But I do have a few questions. Just from personal experience. So I just had a baby. She's 7 months old. I was in the doctor's office for one of my postpartum visits. By the way, you get like one. And she had asked me if I was giving the baby vitamin D. And I said that I wasn't, because I didn't, that nobody told me about it. I didn't even know it was a thing. So I was like, no, I'm not. And she was like, okay. She's like, yeah, if you want to get some, they sell drops like at Walgreens or whatever. And, you could just add them because sometimes breastfed babies don't get enough, vitamin D, She's like, but if you don't get around to it, it's not that big of a deal. And I was like, okay. So I never did because literally my doctor didn't seem concerned that it was a big thing. And it was just like, if you get them, cool. If not, then whatever. So my question, or maybe not a question, but maybe a solution, because what you said was very interesting about that. Maybe a solution would be sort of like a systems change where we're like implementing some policies with our providers, educating them on why it's important, because I feel like there's some sort of disconnect between a provider and a new mother.
Yes.
Really relaying that information, because she didn't make it sound important. So I was like, well, I had a screaming baby in the back seat. I'm not going to go like run around to Walgreens and try to figure out what drops I need for this and that, and so I'd like to hear your thoughts about like the policy, the policy side between the provider and the patient or new mom.
Yeah. I think that's so interesting. I'm so glad you shared that. I've been coming to the same conclusion. This actually was not on my radar until just recently. So, when my son was born, our pediatrician, I think, was pretty clear about, he needs vitamin D. And so we gave it to him pretty early on. But in these focus groups that I've been doing with postpartum women who had gestational diabetes as part of my research study, I wasn't thinking about vitamin D at all, but somehow it came up. Someone mentioned something about giving vitamin D, and another participant was like, I never heard of that. I didn't know I was supposed to be giving them vitamin D. And someone else said the same thing. So it's really interesting to hear you say that and to see in the data that so many people are not complying with the recommendations. I do remember I didn't include it in the presentation, but I came across a statistic. I think it said that 74% or somewhere around there of parents had been recommended to supplement with vitamin D. So they had heard from their providers, but that's not enough. That means 25%, a quarter of people haven't even heard that. And then of the people who received the recommendation, a smaller proportion actually did it. So yeah, I'm very interested in this as well. And I think you're right that maybe we do need some sort of provider education or some intervention with providers.
Like a local health or a WIC intervention where it's just like a quick letter to the provider, make sure you're encouraging this with your postpartum visits and et cetera, or even OBGYNs.
Yes.
And you had mentioned something that really sparked my attention too with the breastfeeding, how it should start in pregnancy. So that's like more education with the provider of, talking to the patient. How do you plan to feed your baby and what, some sort of conversation, because I don't know if I was really ever I am a breastfeeding advocate, and I do breastfeed my daughter Lillian, but it's funny because you mentioned the formula piece. When my son was born a few years ago, we were in the hospital and I was having trouble latching and all this stuff. And they came right in and they were like, do you need formula? Like, it wasn't really like a whole, okay, well, like the education piece, like, let's teach you how to latch on and like, let's, keep practicing sort of thing. So yeah, thank you for really saying that these things definitely resonated.
Yeah. Well, I mean, I guess I'm glad to hear it's resonating, but I'm also not glad that you didn't have all of the information that you should have had, and you didn't have necessarily all of the support you should have had. But it's interesting that you mentioned that about prenatal education, because that's something else that I'm starting to see come out of my focus groups.
Yeah.
We've had many participants when we ask the question, what did your provider tell you or share with you about breastfeeding while you were pregnant? And virtually all of them say nothing.
Yeah.
They say, I heard nothing about breastfeeding when I was pregnant. So I do think that's a need as well.
Sorry, those were all my questions. Thank you. Great job.
Thanks.
Do we have anyone else who has a question? Either that you'd like to shout out or put in that chat box.
Hi, this is Barbara from the East Shore District Health Department. This was an interesting talk, but I think one big missing piece of this is culture. And when I say culture, I don't necessarily mean a country somebody's from, although that can make a difference too. But, people's means, people's families, all those things go into how people feed their babies.
Yes.
And
Oh,
I do
100%.
some toddler education, toddler nutrition classes. And I talk about what basically you had talked about, which is like kind of giving guidance to the parents on, how they can reduce the amount of salt, reduce the sweetened beverages stuff. But there is a lot that goes into these decisions of what parents do, and a lot of it's family and how people were raised and what the grandparents do, and how much money these people have or how much time they have. I mean, I run into a lot of families with very little time, frankly.
Yes.
People working several jobs, people, handing off the baby back and forth. It's not an easy fix.
Yes, you're totally right. And I think the fact that there weren't a lot of evidence-based interventions that I could point to is just proof of that there is no easy fix. And I think the reason why it's been so difficult to develop effective interventions to really change children's diets is for all of the reasons you mentioned, because it is so multifactorial, and it is the result of generational practices and culture. And those are not things that we can easily change by just putting out a recommendation. So thank you for bringing that up.
I see we have a question in the chat box, which says, what is the role of dietary supplement on childhood nutrition? Any recommendation? Okay,
so I mean, I think evidence is pretty clear, certainly for vitamin D supplements, and at least iron fortified foods. As far as for, I don't know if this person's asking about multivitamins or other types of supplements, I would have to do a deeper dive into that literature before I could speak confidently on it. I think in general, in the United States, we have low levels of inadequate intakes of most micronutrients, with the exception of the ones that I've shared today, which are more prevalent, which is why they're specifically addressed in the dietary guidelines. I think other types of supplements aren't mentioned in the dietary guidelines because they're not issues of public health relevance, meaning that they don't affect a wide range of children in the United States.
you. Anybody else have a question? The 3.5 minutes we have remaining.
I'll just say, feel free to email me if you have any other questions or anything you want to discuss after this presentation. I'm happy to be in touch with any of you.
Yeah, I have a quick question here, which is,
Okay.
since CPHA is home to the Community Health Workers Association of Connecticut,
Mhm.
I'm wondering what, if any, role you could envision for community health workers in advancing this.
That's a great question. So, I mean, I could see community health workers being involved in maybe providing some of that education and support related to breastfeeding and other infant and early childhood feeding practices, you know, perhaps doing home visits and providing this kind of guidance directly to parents in a, you know, one-on-one fashion. I could see that being a role for them.
Thank you. Oh, one very quick last question I see from Luz. Additionally to recommending reducing screen time, what about reducing sweet drinks? Any evidence on that? I'm going to say, before you answer that, that is, I think, going to have to be our final question for this webinar.
Yeah. So certainly reducing sugar sweetened beverage consumption is an evidence-based recommendation. So we certainly can encourage people to do that. As far as, you know, is there an approach to sharing that recommendation or supporting it that leads to behavior change? That I'm not sure about. It's not something that I came across in my preliminary research, but I would have to look into that more. But certainly the advice to reduce sugar sweetened beverage consumption is 100% evidence-based.
Right. Well, I think with that, Kim, thank you so much. We are fresh out of time. Thank you for being here. Thank you for helping us support National Public Health Week. And I will just say that I really love how solution-oriented your presentation is here. It is so easy in so much of public health to get bogged down on the stuff that is not going right. I think that having an evidence-based approach to public health sort of drives us in that direction. So it's super refreshing to hear all of these great potential solutions coming at it from lots of different angles. Thank you so much. Thank you, everyone who is here for having been here. Everybody.
Bye.